hearts, and how she was suggesting that we could still have true single left and true single right ventricles. And Dr. Silverman had proposed that that was in the situation where in the clinical setting it might not be possible always to identify, for example, the incomplete left ventricle when the right ventricle was dominant. And I confessed last week that I had not seen Dr. Cohen's presentation. So I revisited Dr. Cohen's presentation, which, as you know, is available for everybody on the Congenital Heart Anatomy YouTube. And in fact, that wasn't how she was anticipating problems in the description of single right or single left ventricles. And what she was suggesting was that we should distinguish those hearts which I have suggested are acquired diseases of fetal life, where both of the ventricles are normally formed, but one is grossly hypoplastic, as opposed to the situation in which one of the ventricles is not only hypoplastic, but is also incomplete. So what I'd like to do today is to go through these problems with you again and to restate my opinion, and then hopefully we can come to an agreement with Dr. Cohen and we can establish precisely why she wishes to deny ventricular status to one of the chambers we find in the ventricular mass. Because as I will also explain, we went through that process quite some time ago, and for us, it did not have a terribly happy ending. So we gave up on trying to disqualify one of the chambers from ventricular status. So that's what I want to discuss with you today. Is there any justification when there are two chambers within the ventricular mass to deny one of those chambers its ventricular status?
Perfect. Elio.
Sure. Hi, good morning.
Video, Elio.
Sorry.
Puoi aprire il tuo video.
Okay.
Perfetto.
Right. Sorry. So, good morning, good afternoon, good evening from Congenital Heart Academy. And we can follow in our LinkedIn or social media and a YouTube channel. So we do a lot of webinar. So there are real new series about diagnosis. And yesterday we do the first hour nightmare case from the first episode from Ashwan Cardiac Jacob Foundation Center. And at the end of October will be an Italian webinar, and it will be a special guest. She is Anne Mary from Texas. She will introduce Dr. Bernowski, and for our is an honor to have her. And so there are the next meeting with webinar with Dr. Prof. Silverman about ventricular septal defect. And today is for the pediatric and cardiology for surgeon is a very, very important day. Today is welcome to true single ventricle and webinar of classroom and Professor Bob Anderson. Thank you.
Good morning, everybody. Good evening, good afternoon. My name is Gil Warnofsky. I'm going to see if I can get this up on the screen. I wanted to, before Dr. Anderson speaks about functional univentricular hearts and the nomenclature classification, which in some ways has almost become religious in terms of the us and them schools of approach. It's ironic, sadly ironic, that I would like to announce the passing of a giant in our field, Dr. Paul Weinberg. Paul Weinberg died last evening after a battle with cancer. He's survived by his wife, Linda, and I don't know the exact number, but I think it's 3 children. And I don't know the exact number, but he was one of the happiest grandfathers in the world and probably one of the best grandfathers in the world. Paul has trained probably or helped train 250 at least practicing pediatric cardiologists and cardiac surgeons. He was a practicing pediatric cardiologist as well as understanding the anatomy of the heart better than most of the planet. And his descriptive analysis was from the school of Richard Van Praagh. And although he didn't see eye to eye with Professor Anderson on many different topics, I was fortunate enough to sit in on a number of their discussions, which I learned quite a bit from. This is from one of our meetings in, I think, Florida, where Paul was using the head cam. And to hear the two of them describe a heart was really one of the highlights of my career. This is a real hallmark of Paul. He was a happy man. He was loved by his teachers and his students, and of course, all of us as colleagues. I found this, Bob. I don't know what the two of you were doing, but it was one of the funnier pictures. And in this solemn moment, I really do want to acknowledge the fact that Paul was just a truly amazing man. And although we can be sad, we also can celebrate his life, which was truly, truly fantastic. This is he and his wife, Linda. So please keep them, please keep Linda and the family in your prayers. It's, again, sadly ironic that today we're talking about in one school, single ventricle, and in another school, a functionally univentricular heart. There are nomenclature differences, but I'm sure there's many more similarities than differences. And on that note, I will turn this back over to Professor Robert Anderson. We go way back, Bob. I'm really looking forward to your talk. You need really no introduction, but I will make an introduction. I was fortunate enough to help edit the fourth edition, which is now appropriately named Anderson's Pediatric Cardiology, which really is the hallmark of our field in terms of anatomy and that anatomico-pathophysiologic correlation and long-term outcomes. So I really look forward to your talk today, Bob. Thank you.
So let's get down to the nitty-gritty and let's ask the question, can there be a true single ventricle? And you must remember that I am approaching this problem from the stance of an anatomist. So to me, as an anatomist, a single ventricle is when the ventricular mass has but a solitary chamber. Does this exist? It does, but it is exceedingly rare. Most of the examples I've seen, such hearts with what I would call solitary ventricles or true single ventricles, are found in the setting of isomerism. But very rarely, we can also find this in the setting of usual atrial arrangement. So when I spoke to you previously, I showed you this image, because this is the nicest example I have ever seen of what I would call a true solitary ventricle. I've opened the heart in clam-like fashion. So there you see both atrioventricular valves opening into the solitary ventricular chamber, and the chamber gives rise to both arterial trunks. Now you will note that it has very coarse apical trabeculations. And this is one of the problems, because this could be a right ventricle. But in fact, the trabeculations are even coarser, what we find in the right ventricle. And the only septal structure within the heart is the muscular outlet septum. So the essence, true single ventricle, for me, is the absence of an apical ventricular septum. And over and above that, the solitary ventricle has indeterminate apical trabeculations. So why is it that some clinicians still want to describe what they call single ventricles? And that is what we were discussing last week. And in Dr. Cohen's presentation to the Congenital Heart Academy, she described a whole series of individuals that she considered to have true single right ventricles or true single left ventricles. But the presence of one big and one small ventricle, with the small ventricle being incapable of supporting the systemic circulation, was what we used to call single ventricle. And what I hoped I'd clarified in my previous presentations to you was that for me, this arrangement in which both the circulations have to be supported by just one of the chambers in the ventricular mass is not anatomically a single ventricle, but is functionally a univentricular arrangement. And in my opening presentation to you, I emphasized what I saw as the consequences for you as clinicians when you recognize this arrangement. Because when we have functionally univentricular arrangement, you are all well aware that this is when you opt for creation of the Fontan circulation to provide definitive palliation instead of opting for treatment by means of biventricular circulations. But as we also discussed in the series of presentations I gave to you on this topic, nowadays, the majority of the individuals that you put forward for conversion to the Fontan circulation happen to have two normally constructed ventricles, but with one of those ventricles being grossly hypoplastic, despite the fact that it has all three of its normal components. And the classical example we see is the hypoplastic left heart syndrome. And as I emphasized to you, in the severe end of the spectrum, which we call pulmonary atresia with intact ventricular septum, when the mural hypertrophy has squeezed out the apical trabecular and the outlet components, leaving only a hyperplastic inlet component, those individuals also frequently are now put up for conversion to Fontan circulation, and that makes them functionally univentricular. What I emphasized also to you is that I view these lesions, these spectrums of lesions, as being acquired diseases of fetal life. Because when we look at these hearts, essentially, they have concordant atrioventricular, ventricular arterial connections, and the real key is that they have an intact ventricular septum. But we also know that there are some individuals going forward for the Fontan circulation who do not have acquired diseases of fetal life. And the essence of these lesions is that there is unequal sharing of the normal components of the ventricular mass between the apical parts. And by my understanding, it is these individuals that Dr. Cohen is now suggesting we should be interpreting as having either true single right ventricles or true single left ventricles. But does this really produce hearts in which either the left ventricle or the right ventricle is a solitary entity? Well, of course, this depends entirely on how we define what we are going to call a single ventricle. So let's look at this potential concept in the context of the normal heart. So this is a cast I made a long time ago of a normal heart. And as you see, we have cast the right side of the heart in blue latex. We've cast the left side of the heart in red latex. And unequivocally, at the front, we have the right ventricle. And in this particular heart, this is the only right ventricle present. So it is a single right ventricle. But then at the back of the heart, we also have a left ventricle. And this is the only left ventricle present in the normal heart, so it is a single left ventricle. So there's no question that all of us have single right ventricles, but they happen to coexist with single left ventricles. So are we justified in considering true single right or true single left ventricles when the hearts in question are congenitally malformed? Well, the only way we can do that logically is by disqualifying one of those chambers within the ventricular mass from its ventricular status. Because if we did disqualify one or other of those chambers, then indeed there would be a single right or a single left ventricle. But for me, this is déjà vu all over again. Now, many of you will know that this quotation is allegedly due to Yogi Berra, the catcher for the New York Yankees. And allegedly, Yogi made one of his many statements when he watched Roger Maris and Mickey Mantle hitting home runs back to back because he'd seen it happen before. That itself is controversial, but Yogi himself accepted that as the source of déjà vu all over again. So why is this déjà vu all over again for me? And it is because a long time ago now, in the late 1970s, when I was working with Fergus McCartney and Barry Keaton, we came across this heart that Fergus had done angiography in when he was at Great Ormond Children's Hospital, Great Ormond Street Children's Hospital. And what you see is that we have a chamber which might indeed be considered a single right ventricle. It has double inlet through a common atrioventricular valve, and it has obvious double outlet. But what we noticed was that tucked away in the hip pocket of the ventricular mass was this second ventricular chamber. And we now know that this chamber is an incomplete left ventricle. And I'll come back to that. But in the setting of this heart, it is the only left ventricle present, so it is an incomplete single left ventricle. But at the time, we wanted to disqualify this chamber from ventricular status because we wanted to call this heart a univentricular heart of right ventricular type. So here is the paper we published. As you see, Barry Keaton, first author, together with Fergus McCartney, Elliot Scheinborn, with whom I was working at the Brompton at the time. Michael Tynan was then at Guy's Hospital. Jim Wilkinson was still involved, along with Stuart Hunter and Carlos Mortera from Newcastle, and Phil Rees also from Great Ormond Street. So we wanted to call these hearts univentricular hearts, and the only way we could do it was by disqualifying that small chamber from ventricular status. Now here is the key point in these discussions, because our paper published in Circulation attracted this letter from my good friend Richard van Praag. And here you see the key to what we are discussing today, because Richard pointed out that those individuals having a big right ventricle and a small right ventricle did not have single right ventricles. And this was the essence of what he subsequently called the morphological method. And he pointed out we should use the most constant component of any chamber to distinguish between whether it was morphologically right, whether it was morphologically left. We should not be using variable features to define other structures which were themselves variable. And in that setting, we were disqualifying small chamber from ventricular status because it did not have an inlet. And we immediately appreciated the logic of Dr. Van Praag's letter. So since then, we have never sought to disqualify small chambers from ventricular status if we could identify them as incomplete ventricles. But it seems that Dr. Cohen wants us to go back to that situation. And to me, that does not make a lot of sense. So what was the essence of what we were saying? We were trying to define the univentricular heart because it had double inlet. And this is another of the hearts we had at the time. There you see the right atrioventricular junction, left atrioventricular junction, and they are both connecting to this big ventricle that has coarse apical trabeculations. And it could indeed be the case. This is a solitary ventricle of indeterminate morphology. So as I've already said, the way we know this is not a solitary ventricle is when we turn it round. Because here in the hip pocket, that heart I showed you just a moment ago, we have a very well-formed chamber that has unequivocal left ventricular apical trabeculations. And more important, it has part of its inlet still remaining, although its junction is committed, the junction that should be coming into this left ventricle is committed into the right ventricle. So there is no question that when we have double inlet right ventricle, we can identify that big chamber as a right ventricle, we can find a second chamber present, and that chamber, as Dr. Van Praag pointed out, is unequivocally of left morphology. And that is because it possesses the apical component of the left ventricle. And also, on occasion, it can have part of the left ventricular inlet. Now, here we come to another of the problems, because Dr. Cohen was describing the ventricular inlets as the ventricular sinus. And if I understood things correctly, she was going to disqualify ventricles from ventricular status when they lacked a sinus. So this all depends on the definition of a ventricular sinus. And again, we're here, déjà vu, all over again. Because I introduced you in my opening presentation the problems we had when I started in the field with tricuspid atresia. Because at that stage, tricuspid atresia was considered a biventricular heart. And that is because when we look at this small chamber in the setting of tricuspid atresia, the blood comes into it through a ventricular septal defect, but unequivocally it has an apical component. At the time, people were calling this a sinus. And it also has a long infundibulum or conus, and in most instances, in the setting of tricuspid atresia, as we have discussed, the conus supports the pulmonary trunk because we have concordant ventriculo-arterial connections. So there's no question but that tricuspid atresia has one chamber that is big, one chamber that is small, and we can all agree that the big chamber is the morphologically left ventricle. So if we are going to say that tricuspid atresia is a true single left ventricle, we have to come back and we have to define the nature of that small chamber. Is it an infundibular outlet chamber, or is it the incomplete right ventricle? And again, this comes back to what I've discussed with you before. It all depends on how we analyze normal ventricles. So let's look again at normal ventricles, and let's emphasize that the ventricular mass extends from atrioventricular junction to the ventriculo-arterial junction, and you will appreciate that here I'm showing you the morphologically right ventricle. And now, if we consider the functional components of the right ventricle, it has an obvious inlet, it has an apical trabecular component, and it has an outlet. And you will note that purposely I am not using the term sinus, because the sinus can be potentially confusing. Because as we've seen, tricuspid atresia has an obvious apical component. I'll come back to that. And some in the past that was called sinus, but it lacks its inlet component. So let's look at the other side of this heart. Again, the ventricular mass extending from the atrioventricular to the ventricular arterial junctions. Once more, when we analyze it functionally, it has an inlet, an apical trabecular, and an outlet component. So what I've tried to emphasize to you is that we can analyze the ventricles in tripartite fashion. And normal ventricles each have 3 parts, but as we have discussed, they are not always normally sized. So in those acquired diseases of fetal life, we have functionally univentricular arrangements because part of the heart is grossly hypoplastic. But as we've also discussed, the reason we are considering these problems of potentially true single ventricles is because when the heart is congenitally malformed and functionally univentricular, the problem is that the inlets and outlets are unequally shared between those apical parts. And it is that unequal sharing that makes one chamber dominant, and the other chamber is not only hypoplastic, it is also now incomplete. So is it logical to deny ventricular status to one to the small chamber in this setting just because it is incomplete? And I do not think it is logical. And nowadays, we can bring additional information to bear because we can look at the way in which the ventricles develop. So earlier in my classrooms for you, I've shared with you this evidence we now have of normal human development. And these are the reconstructions of the cavities of the developing heart prepared by my colleagues in Maastricht, Professor Wout Lammers and Dr. Joe Hickspoors. And this is the early stage. And you see they have colored the atrial chambers in dark blue. There we can recognize the atrioventricular canal, and already at this stage we can see the ventricular loop. And the ventricular loop has an inlet through the atrioventricular canal, and it has an outlet to the outflow tract. And very rapidly after this stage, the heart produces the primordiums of the developing ventricles. So one stage later, we can still recognize the atrioventricular canal, but now we can see that the atrioventricular canal is supported exclusively by what will become the developing left ventricle. And that is because the apical component of the developing left ventricle is forming from the inlet part of the ventricular loop. And at this stage now, we can see that the apical component of what will become the right ventricle is forming from the outlet component of the ventricular loop, which then supports the outflow tract. So these are the reconstructions of a heart made by Wout and Jill from serial sections. We also have episcopic data sets prepared by my other great friend and collaborator, Tim Mohan, and they show you very beautifully what is going on at this early stage. And these are probably easier for you to recognize. So now you will appreciate that you can see the right atrium, see the left atrium, and there is the atrioventricular canal. And at this stage, the atrioventricular canal is providing a common atrioventricular junction, and it is supported exclusively by the developing left ventricle. And then all the blood passes through what we're going to call the embryonic interventricular communication, and it enters the developing right ventricle. So the same heart, I've simply shifted the cutting plane so that I can show you what's happening on the other side of that embryonic interventricular communication. So now you see that the right atrium at this stage has no connection with what will become the left ventricle. All the blood is going to the left atrium, the atrioventricular canal, into the left ventricle, and then through the embryonic interventricular foramen into, unequivocally, the developing right ventricle. So from the outset, the right ventricle has its apical component, although as yet it lacks its inlet component, but it supports the entirety of the outlet component. So what I emphasized to you when discussing this earlier is that initially the developing heart has double inlet, developing left ventricle, double outlet from the developing right ventricle. The significant point for today's discussions, it is the apical trabecular components that form first and permit us to distinguish what will become morphologically right and what will become morphologically left. But at this early stage, both of those ventricles are incomplete. And it is only with subsequent development the right ventricle achieves its inlet, the left ventricle achieves its outlet. And only at that stage are we able to close the embryonic interventricular communication. So I'm just going to show you the initial step in which the right ventricle develops its inlet. So this is the next stage of human development, Carnegie stage 14. You can also recognize now the right appendage with its pectinate muscles, tubular left appendage. Still, we have the common atrioventricular junction at this stage, but now the atrioventricular junction has expanded rightwards. And it is that rightward expansion, the atrioventricular junction, that gives the right ventricle its inlet. But look how tiny at this early stage is that right ventricular inlet. The right ventricle remains a right ventricle because of its apical component. And that is the key to understanding. So it's expansion of the atrioventricular canal that gives the right ventricle its inlet. But we also know that if the expansion is incomplete, we have straddling and overriding of the tricuspid valve. We discussed that last week in the setting of straddling valves. But we also know that if there is excessive expansion, then that is what produces double inlet right ventricle. So how is all of this pertinent to our consideration of single right or single left ventricles? Well, let's look at what happens if the atrioventricular canal expands normally, but septate, because then we have an atrioventricular septal defect. And here I'm showing you balanced commitment of the atrioventricular junction in the setting of atrioventricular septal defect. And there is the phenotypic feature, the common atrioventricular junction. And when we have normal expansion, each atrium is connected to its own ventricle. So there again, we have a single right ventricle, a single left ventricle, their presence in the same heart. But what happens if there is dominance of the right side, and the right side of the junction is greater than the left side of the junction? And this, of course, is what you recognize as atrioventricular septal defect with right ventricular dominance. And the problem then is, when is, in this setting, the left ventricle too small to support the systemic circulation? And when, in this setting, with right ventricular dominance, do you as clinicians have to opt for conversion to the Fontan circulation? And indeed, Dr. Cohen has done much of the work creating potential algorithms to tell us when this hyperplastic left ventricle is incapable of supporting the systemic circulation. But we still call it a left ventricle. We do not disqualify it from ventricular status in this setting. So what happens in the extreme form of expansion of the atrioventricular canal? And this is what happens. We still have a common atrioventricular junction, but now it is supported exclusively by the dominant right ventricle. But there, tucked away in the hip pocket of the ventricular mass, we have this second chamber. Are we now going to deny this ventricle its left ventricular status? Surely not, because it is immediately recognizable as an incomplete left ventricle. And we have a similar situation with straddling and overriding of the tricuspid valve. These are the images I showed you last week, overriding right atrioventricular junction with predominant commitment to the right ventricle. But I also showed you last week that in some instances we can have straddling and overriding of the tricuspid valve when it is mostly connected to the left ventricle, meaning that now the right ventricle is much more incomplete, but it is still a right ventricle. Because here is another heart with straddling and overriding of the tricuspid valve, the right atrioventricular valve, and you see the tension apparatus attached to the crest of the apical ventricular septum, unequivocally the true ventricular septum, with the anterior chamber having right ventricular trabeculations supporting the pulmonary trunk. So this is the other side of that heart. There is the straddling right or tricuspid atrioventricular valve, but now the left atrioventricular valve is also coming into this dominant chamber, which gives rise to the aorta, and which has unequivocal left ventricular trabeculations. Are we now going to call this a single left ventricle when we've seen that the right ventricle in this setting still possesses part of the inlet component? Surely not. And then, of course, that is one of the variants in the Holmes heart, and here is another example of the Holmes heart. And now we see that the right ventricle has its obvious apical component, but lacks its inlet. It has an outlet in the Holmes heart and pulmonary trunk, but in the Holmes heart, the right atrium, along with the left atrium, through their atrioventricular valves, are committed to the dominant left ventricle. Are we going to deny right ventricular status to this small chamber? Surely not. We can recognize it as an incomplete right ventricle because of those apical trabeculations. And indeed, the Achilles heel to our own attempt to disqualify chambers from ventricular status was the presence of a small part of the inlet component or sinus within that second chamber. So in the setting that I've shown you, straddling tricuspid valve, does the small chamber really cease to be a true right ventricle when it has less than half of that inlet or sinus? Again, surely not. Because does that at a stroke define the other chamber as a true single left ventricle, when the normal heart has a true single left ventricle that happens to be associated with a true single right ventricle? Surely the answer to this is no. So what I tried to emphasize to you in my initial presentation, if we are to understand the anatomy, what do we need to do? We need to start by analyzing the atrioventricular junctions, because if anything is single within the heart, it is the atrioventricular junctions rather than the ventricular chambers themselves. So in the setting, double inlet ventricle, or absence of one atrioventricular connections, it is the atrioventricular connections that are truly univentricular, as opposed to being biventricular. But then, of course, it is key that we do describe the ventricular morphology, and when we have univentricular atrioventricular connections, then of necessity, one ventricle will be dominant, the other will be incomplete, but it will still be recognizable as a ventricle because it possesses its apical component. So can we restore logic in this setting? I believe we can. We do have true single ventricles. They are exceedingly rare, but we find them only in the setting of ventricular mass with a solitary chamber. And I would repeat, again, to me, having been through this process a long time ago, it is illogical that we should try to deny ventricular state to chambers of either morphologically right or morphologically left identity. And to summarize again, it is the atrioventricular connections which are truly univentricular or truly biventricular, and it is the analysis of the atrioventricular connections together with ventricular morphology that resolve for us what is going on when we have functionally univentricular arrangements.
Hi, Norman. Hi, Bob.
Hi.
So we have also Carlo Troconis with us that recovered from his normal life. So Bob, or we start with Norman as usual, or we have Gil. Today it's something amazing today for this. So we can start from probably for Norman. Norman.
Well, first of all, I'd like to express my sympathy to all of the people that trained in Philadelphia that are listening today about the passing of Paul Weinberg. He was a personal friend of mine, a gentleman, and a scholar, and he will be sadly missed. So that's my first observation that I have to make. Gil, my sympathies to you. I know he was a good friend of yours. I think that the word for Bob's talk this morning is clarity. It is absolutely clear what he said, and I don't think that anybody could argue with it. The problem that we've got as cardiologists is that we've got bad habits. I think that's really the issue. And we glibly throw around this term single ventricle, which actually should be completely expunged from our vocabulary and our dictionaries, because they are so rare. And I think Bob has made it absolutely clear that it's the univentricular atrioventricular connection which is the key to understanding this, and that when we look at these hearts, we see always, almost always, we see a second little chamber, even echocardiographically. And I think that we have to define these ventricles exactly as Bob has put it. It was very clear that what he's done over the last now 6 weeks is a method which we can all live with. And Bob, I congratulate you for this talk.
Well, thank you very much, Norman. And I would also say how sorry I am to hear of the passing of Paul Weinberg. As Gil pointed out, Paul and I met together many times during the Philadelphia sessions that we had in Orlando. We also had the sessions in Phoenix, in Scottsdale. They were wonderful sessions. We had wonderful times together, and it's very sad today to learn of Paul's passing. And it's it's sad in a way that it should also come on the day when we are discussing the functionally univentricular heart, because as Gil pointed out, Paul trained with Richard Van Praagh, and Richard still maintained you could have single left ventricle. So Paul and I disagreed on that, because as I explained today, I think the only true single ventricle is the solitary ventricle. And I'm not sure why Merrill reintroduced this notion of having true single ventricles, because I don't think it really helps. I can understand, and what Norman and I, in fact, discussed last week, which what precipitated this continuation of this debate, and Norman rightly pointed out. On occasion, when you're dealing with what looks like a true solitary ventricle, it can be a solitary right ventricle, or seemingly a solitary right ventricle, because the left ventricle is so small that you cannot identify it in the clinical setting. And I accept this. I think that is true. But that does not mean we should then extend that concept to argue that all those hearts that I described today as being congenitally malformed, rather than representing acquired diseases of fetal life, there is no reason anymore that we should consider those hearts to have true single ventricles, because I think that is illogical. It doesn't go along with what we now know in terms of anatomy. More important, as I hope I described today, it doesn't go along with what we know about development. So it's a pity. I had hoped that Dr. Cohen would come and we could discuss this directly. Poor Norman is now the amanuensis for Dr. Cohen because she can't be with us. But I think, Norman, I think I've summarized the situation and described what the debate between you and I was last week, have I not? And I've set out the situation again.
Correct. Correct.
Gil,
I'm
this is
very happy with this.
Yes. Gil, please.
I wanted to offer a different perspective, if I may. And Bob, I thought that was fantastic. I thoroughly enjoyed that. As I have learned in editing your textbook, the incredible differences between the American and English version of what should be a common language. I wanted to just put up a slide if I can. Let me just see if this works. While you were talking, I thought it would be interesting for me to just share my view as purely as a clinician. And where I slightly differ with what Norman said, and this is a quote that's attributed to George Bernard Shaw, that England and America are two countries separated by the same language. The problem, of course, is it's also attributed to Winston Churchill. So as you can see, at least on the internet, and you know, if you see it on the internet, it must be true. There's always sort of two ways to look at this. And as I was looking through this, we're terrible in the United States from a language perspective of dropping words and changing words and making assumptions. And especially, as you've pointed out, Bob, to me on multiple occasions, using abbreviations when clarity is really what we're looking for. And to me, as I hear your compelling talk about, quote, single ventricle, of which they are exceptionally rare, I think to me it is an example of Americans dropping the most important word here. I don't think many people know, but Detroit in the United States is actually Detroit City, but like New York City, but everyone has dropped the city. And if you say Detroit, you know where it is. You know exactly what that city looks like. And that's typical for us here. We know how different our vocabulary is. I was just finding these on the internet while you were talking. There's hundreds and hundreds of these differences between the words that we use. So I realized in working with you on the book, and I currently use the term functional univentricular heart all the time now. And I've used parts of what I learned from Paul and Richard and parts of what I've learned from you. It's a bit of a hybrid. Truly, there is exceptionally rare, I completely agree with you, single ventricles, univentricular hearts. The key in the clinical state is the word functional. So that if we had to think of the word that we've dropped that's incorrect, is the term functionally univentricular heart, or even functional single ventricle. And we had this discussion in talking about where we were going to put pulmonary atresia intact ventricular septum in the book, because I was defining it as a treatment strategy, and you corrected me and said it should be treated as an anatomic diagnosis, that I had two different treatments. So, where I've come on all of this now is that for me, the controversy here is that we need to be accurate in terms of the diagnosis. And in that case, your descriptive stuff, there are no true single ventricles. In shorthand, however, when we are walking in the unit or describing a baby that just came in, this is a baby with double inlet left ventricle. I know there's an RV pocket somewhere, but that's a functionally single ventricle as we move down the pathway. So those were the only things that I wanted to add to this discussion. And your description has convinced me of calling this functionally univentricular heart on a clinical grounds. Thanks.
Well, Can I mean, if I can come back to that, I agree with everything that you say. And to me, as I tried to point out during my presentation today, what I think Meryl was trying to do when she gave her talk on the echo of what rightly you say is functionally univentricular heart, she was trying to distinguish the two groups within that entity. And I agree that those groups exist. And they are the groups that, as you say, like pulmonary atresia within, or part of pulmonary atresia with intact ventricular septum, which, as you say, can be a functionally univentricular heart. The other half of pulmonary atresia with intact ventricular septum is a functionally biventricular heart. Hyperplastic left heart syndrome, with almost always, is a functionally univentricular heart. And that is because those lesions, as I tried to clarify today, have acquired diseases of fetal life. When the heart starts off after 8 weeks of development, after cardiac development essentially has been normal, something goes wrong. So half of the heart doesn't grow properly. And they are fundamentally different from those other hearts, which I suggested were congenitally malformed, when whatever made those hearts go wrong, the insult happened before 8 weeks of development, so before the heart had completed its normal development. And I have no problem with what Dr. Cohen was trying to say with there are those two sets, but I think then to go back and to say let's differentiate them by calling one set true single ventricles, the other set not untrue single ventricles, to me that just doesn't make sense in what you said, Gil. I think by emphasizing the functionality, I think that brings everything into focus. And as you say, the important word there is not univentricular. The important word is functionally.
Right, or single, right? The important word is how are we?
Absolutely, right. I have no problem whatsoever with functionally single heart, because that's what you as clinicians are dealing with. But let's not go back 40 odd years, and let's not refight this whole argument as to what makes it anatomically a single ventricle. Because I think Richard Van Praagh was right. We were 100% wrong when we tried to disqualify one of the chambers from ventricular status. And if I understand correctly, what Meryl was saying in her talk is she still was suggesting it might be a good idea to disqualify one of the chambers from ventricular state. That has to be a backward step rather than a forward step.
Well, again, Meryl's not here to, I certainly, I'm not nearly as articulate as Meryl would be, nor as knowledgeable as Meryl would be. To me, this discussion in all candor is theological as well as rheological. And those are important discussions to have without question, so we understand the formation of the heart. I'm not going to say the word but, I'm going to say at the same time, I think we understand, we keep trying to improve this. We may go backwards, we may go forward. And I don't want any of the people in the class to forget the notion that in addition to being anatomically precise, we are also obliged to say which direction, how does this imply what treatment should be given to the patient?
I couldn't agree more with you, but I think that and what I tried to stress during my presentation today, the one thing that has been lacking previously is we've not been able to understand how these things develop. And you will know, Gil, that for years, pediatric cardiologists have always been concerned about the morphogenesis. What is the morphogenesis of the lesion? And previously, we've always invoked speculation to do that, and we don't need to speculate anymore, because I now truly believe that we can look at normal development, as I tried to show today. We can look at the mechanisms of normal development, and we can relate those mechanisms to, on the one hand, the acquired diseases of fetal life, and on the other hand, the congenital malformations that take place before we get to the completion of what essentially is normal development. And we have to remember that is taking place 8 weeks, 9 weeks of gestation. And then in the human situation, you have another 30, 32 weeks before the baby appears. And those are now we can concentrate on so much on those weeks. That's what the fetal cardiologists do. So with all of this now, and with the advances that are being made with fetal intervention, it's important that we relate these all together. But I take your point 100%. We must not forget the functionality, and we must not forget the significance of establishing the appropriate treatment.
Yeah. I'd like to broaden this discussion a little bit, because I think there are a number of nagging issues. The one is, how do we teach the younger generation about what to say? And I think that Gil, you and I understand when we glibly talk about single ventricle that we've dropped the functionally out of this argument. But I think that we need to explain to the future cardiologists that these are really functional connections. The other issue is, what do we tell our genetic colleagues? Because clearly there is a difference in the genetics of something that happens later in gestation to cause maldevelopment of one or other of the ventricles, as opposed to what we see in the developing heart, where we see that this functionally single ventricle is much earlier in its developmental timing. So those are the issues that I think are valuable, and we really have to be careful about glib nomenclature.
I couldn't agree with you there, and you're right, absolutely right there, Norman. And the point you make about what we tell the geneticists and how we counsel these people is, for hypoplastic left heart syndrome, that is absolutely key, because a lot has been written over the past 2 or 3 years, particularly by Cecilia Lowe's group from Pittsburgh, who maintain they have produced mouse models of hypoplastic left heart syndrome. And that is simply not true, because all of Cecilia Lowe's models either have double outlet right ventricle, or they have transposition, or they have atrioventricular septal defect, and they have perturbed their mice so that they produce functionally univentricular hearts, but they are not mouse models of hypoplastic left heart syndrome, because they're not showing us acquired diseases of fetal life. So I agree with you there 100%. We've had a couple of questions that have come in, and I've just been reading them on the question and answer, and these are also pertinent. So Abhinav Agarwal has asked, is there any structure that will still be defined as outlet chamber or rudimentary chamber? To me, the answer there is unequivocally no, because we know that the so-called outlet chamber has an apical component of right ventricular type. It is an incomplete right ventricle that is also rudimentary. And then Miguel Angel Arizapana Arapa, however forgive me
awesome.
if I pronounced it wrong, asks, is the single ventricle a preterm heart, or is it another type of ventricle with abnormal drainage, isomerism, alteration of the AV valve and of the outflow tract, especially in the right type? And the latter part of that, again, is true, because all of those things can be seen when the small chamber in the functional univentricular heart lacks one of its component parts. And in fact, we can also argue that when you have double outlet right ventricle, the left ventricle is incomplete because it lacks its outlet. But in that setting, nobody has ever disqualified the left ventricle there from ventricular status. So to me, I come back now echocardiographically, and this is what Merrill was saying, I think. You can define these parts. You can define which is the inlet, which is the outlet, which is the apical part. So with modern day technology, you can see these things. And Norman, you can comment to this also. You can see this during fetal life, can you not? And you can see
Absolutely.
whether the two ventricles are normally constituted, with those rare exceptions, which is what you and I were discussing last week, when you have a big chamber and you are not entirely sure whether it's a right ventricle or whether it's indeterminate, because the left ventricle might be so small that it's unrecognizable. And I must admit, I've seen hearts like that in the autopsy room. We didn't find the left ventricle until we serially sectioned it and found a tiny slit which had the left bundle branch within it.
Right.
No, there is a question, I don't want to make it, but is a big opportunity to have Bob and Norman and Gil together. The question is, we can be able to make some consensus about official nomenclature and or classification. Bob.
I mean, to me, that's what we have been trying to do with the International Nomenclature Committee. And we have striven to gain a common language. And Meryl and I are both members of the International Nomenclature Committee. So I was surprised when she came up with this what to me was a reversion to arguments we'd had 40 years ago, because I thought we had agreed that by adding functionally, we could achieve consensus. And hopefully, I agree with you 100%, Sasha, we have to try and achieve consensus. And what Gil was saying, that it's trying to be shorthand, going back to you again, Gil, it's being a little bit lazy and dropping the most important word, which is functional. And if we have functional single, functional univentricular, hopefully we can achieve that consensus. And I think these discussions we're having through the Congenital Heart Academy are a very important way of focusing on the need for what Sasha says. We need a universal language. Where now the Congenital Heart Academy is broadcasting all the way around the world. We have people listening to us. They beam in, they can catch up with what we've been doing. They can go to the YouTube Congenital Heart Academy website. And this is the opportunity, surely, that we have to emphasize that we need, ideally, to be speaking the same language. I mean, Gil, you might want to say more to that.
I wish that the Brits and the Americans could speak the same language.
Well, we're trying. We are trying. As you know, I'm trying to persuade everybody now to speak American rather than use Latin. So
I don't know whether the term is that we're lazy, but it's contractions continue to happen, and the push for me in the clinical end is to always emphasize the word functionally. When the echo report comes out and when Norman does his work, Meryl does his work, when my colleagues do their work, the details of all the different parts are very, very important. When I'm on rounds, however, I'm going to be calling it, it's a functionally single ventricle and they need a pulmonary artery band or whatever it might be. This is an and, not an or, right? There are two ways to look at this. There's the complete anatomic way, and I do agree that you and Meryl will agree probably in 95% of what that is. And that's cool. That's great. As a clinician, we should not, and I agree, I don't know, Norman, whether we should drop the term single ventricle, but we definitely should not drop the word functionally. That tells us quite a bit.
Yeah, I think we should look to Bob for guidance on that, but I think that he's been pretty clear about that.
I know I'm not. I don't want you, as Gil said, if you call it a functionally single ventricle, I have no problem with that at all, because that's what it is. There's only one ventricle capable of supporting the circulation, and in that setting, it is a functionally single ventricle. There happens to be a functionally a ventricle, a second ventricle present in 98% of cases that is functionally incapable of supporting one or other of the circulations. And surely that's the point we should be emphasizing.
Bob, would you agree with the term anatomically biventricular, functionally single ventricle?
Absolutely. But are we ever going to get anybody to use all those words?
That's why I just said functional single ventricle.
Yeah. But I think that adding, as you say, adding functional says it all. So I would not want to stop people saying functionally single ventricle or functional single. I mean, as you know, I like to use adverbs of adverbs. So as functional is an adjective and functionally is the necessary adverb. But I can cope with functional single ventricle.
Very good.
I must say that in the term functional single ventricle, my paradigm shift of understanding is that I would classify hyperplastic left heart syndrome and pulmonary atresia with intact septum in the group of functionally single ventricles, although to me they are separate as chalk and cheese. Indeed,
but is that not oftentimes the case? We put things together, and It depends on why we're going to group things. We group things together when they have things in common. So, and on one occasion, I was criticized in the nomenclature committee because I wanted to group things together because they had similar surgical treatment. And I see nothing wrong with doing that. And I was accused of prostituting myself to the surgeons. And if that's the case, I make no apologies for being a prostitute, because we have to explain these things to the surgeons. And so I see no problem in grouping things together when they have things in common, separating them out according to what they have that are different. That's the whole essence of Linnaean classification. We have the genus and we have the species, and there are many genuses and there are different species that we put together. And for congenital heart disease, we group things together for different reasons, do we not?
Is that the same as Sicilians and Italians? I thought I would end with a non-controversial topic.
But the Italian will be not able to understand Sicilian. It's not like English in America.
I'm going to have to run. I have an appointment, and it's been really great, everybody. Bob, Norman, Elio, Sasha, very good to see you all.
Thank you very much. My sympathies.
Hopefully we can move towards consensus.
Yes.
Yeah.
So we will ask Bob, we will see on Tuesday.
We will indeed, and we will next week, we will commence again and we'll move forward with, we'll do isomerism for next week. And then we will move towards systemic venous anomalies.
Perfect. Norman, thank you very much.
Thank you very much, Sasha. Great. Goodbye, everybody.
Bye, everybody. It was a good discussion.